You went to bed last night feeling completely fine. No chest pain, no dizziness, no warning of any kind. And sometime during those 8 hours of sleep, while your family was in the next room, while the house was quiet and still, something happened inside your brain that you had absolutely no awareness of. For some people, they wake up and discover that one side of their body no longer responds. Their speech comes out as garbled sounds, their face droops on one side when they try to smile at the person they love, and the terrifying part is not just what happened, it is what caused it. Because in most of these cases, it was not smoking. It was not a lifetime of fast food. It was not skipping the gym for 20 years. It was something they did the night before that they believed, with complete and total confidence, was perfectly healthy, maybe even beneficial. Here is a number that changes how most people think about their mornings. Every 40 seconds, one American has a stroke. Every 3 minutes and 30 seconds, one American dies from a stroke. And adults over 60 account for more than 75% of all stroke deaths in this country. But here is what most people never hear from their own physician. A significant number of those strokes were not inevitable. They were not random. They were the result of specific habits, specific foods, and specific nighttime routines that quietly set the stage over hours, days, and years. Today, we are going to change that. We are going to walk through 18 specific risk factors that most people over 60 are living with right now without any awareness. 9 of them involve foods you may be eating every single day. 9 of them involve things you do every single night before and during sleep. And by the time this conversation is over, you will have the knowledge to protect yourself and the people you love starting tonight. If you often wake up with unexplained headaches, feel unusually tired after a full night of sleep, or have noticed that your thinking feels slower or foggier than it used to after 60, this video is for you. Welcome to the Stronger Seniors Podcast. I am Dr. Daniel Brooks, and joining me today is Dr. William Carter, a physician and neurologist with 33 years of clinical experience dedicated entirely to helping older adults understand and protect their cardiovascular and neurological health. Dr. Carter has worked with thousands of patients, many of whom came to him after experiencing strokes or TIAs that they never saw coming. And over those 33 years, he has identified patterns, specific repeatable patterns, in the habits and routines that precede these events. Dr. Carter, I want to start with the most basic and most important question. When we talk about stroke in adults over 60, what are we actually talking about, and why does this age group face such a fundamentally different level of risk than younger adults?
Daniel, that is exactly the right place to begin. Because I think one of the most dangerous misconceptions about stroke is that it is something that happens to other people, people who were already sick, people who had obvious risk factors that everyone could see. And in 33 years of practice, I can tell you that is simply not true. Some of the most devastating strokes I have witnessed happened to people who were active, health-conscious, and doing everything they believed was right. So let us start with what stroke actually is. At its most fundamental level, a stroke occurs when blood flow to a region of the brain is interrupted. Brain cells begin to die. And depending on which region is affected and for how long, the consequences can range from temporary weakness to permanent paralysis, from mild speech difficulty to complete loss of language, from slight memory disruption to total cognitive collapse. What makes stroke so uniquely terrifying compared to other cardiovascular events is the speed at which damage occurs. When blood flow stops, brain cells do not have the luxury of time. Research published in the journal Stroke and confirmed by the American Heart Association tells us that every single minute a stroke goes untreated, approximately 1.9 million brain cells die. In 1 hour without treatment, the brain ages the equivalent of 3.6 years. That is not a metaphor. That is a biological reality that determines whether a patient walks out of the hospital or requires full-time care for the rest of their life. Now, why does age 60 become such a critical threshold? Several things happen to the cardiovascular and neurological system as we cross into our 60s that simply did not apply when we were younger. First, the arterial walls. In your 30s and 40s, your blood vessels are elastic and responsive. They can adapt to changes in pressure, position, and blood chemistry with remarkable efficiency. After 60, those walls begin to stiffen. The medical term is arteriosclerosis, and stiffer vessels mean two things. They are less able to accommodate sudden changes in blood flow, and they are more susceptible to the kind of microscopic damage that creates the conditions for clot formation. Second, the blood itself changes. Platelet aggregation, the tendency of blood cells to clump together, increases with age. The natural fibrinolytic system, your body's built-in mechanism for dissolving clots before they become dangerous, becomes less efficient. And many of the medications that people over 60 take routinely, for blood pressure, for diabetes, for cholesterol, interact with food and other substances in ways that can dramatically shift the balance between clotting and bleeding. Third, the heart. After 60, the risk of atrial fibrillation increases substantially. And I want to spend some real time on atrial fibrillation today because it is the single most underdiagnosed cardiovascular risk factor for stroke in older adults. We will come back to it in just a moment.
Dr. Carter, before we go further, I want to make sure our viewers understand the full picture of what we are dealing with. Because when most people hear the word stroke, they picture one thing. But you have told me before that there are actually 4 distinct types of stroke, and understanding the differences matters enormously for prevention. Can you walk us through them?
Absolutely. And this is genuinely important knowledge, because the prevention strategies, the warning signs, and the risk factors differ depending on which type we are talking about. The first and most common type is ischemic stroke. This accounts for approximately 87% of all strokes. An ischemic stroke occurs when a blood clot blocks an artery supplying blood to the brain. There are 2 mechanisms. In a thrombotic stroke, the clot forms directly at the site of a narrowed or damaged artery, typically one that has been gradually narrowed by years of atherosclerotic plaque buildup. These strokes often occur during sleep or in the early morning hours, precisely because blood pressure is at its lowest and circulation is slowest during those hours. In an embolic stroke, the clot forms somewhere else in the body, most commonly in the heart, and travels through the bloodstream until it lodges in a cerebral artery. This is the type most commonly associated with atrial fibrillation. The second type is hemorrhagic stroke. This accounts for about 13% of strokes, but carries a disproportionately high mortality rate, over 40% in the first 30 days. A hemorrhagic stroke occurs when a blood vessel in the brain ruptures and blood floods into the brain tissue itself. The most common causes in adults over 60 are uncontrolled high blood pressure and a condition called cerebral amyloid angiopathy, where a protein called amyloid gradually weakens the walls of the small blood vessels in the brain over decades. This is one reason why some of the medications and foods we will discuss today carry particular risk. When you add blood-thinning effects to vessels that are already fragile from amyloid accumulation, the consequences can be catastrophic. The third type is TIA, transient ischemic attack. Most people have heard the term ministroke, and that is essentially what a TIA is. The blood flow interruption is temporary, usually lasting minutes to an hour, and symptoms resolve completely. The danger is that most people, when their symptoms disappear, assume the problem has resolved as well. It has not. Research published in The Lancet has shown that within 48 hours of a TIA, the risk of a full stroke reaches between 10 and 15%. Within 90 days, that risk climbs to between 10 and 20%, with the danger highest in the first 2 days. I have had patients tell me they experienced arm weakness or slurred speech for 20 minutes and decided to wait and see. Some of them did not get a second chance. The fourth type is cryptogenic stroke. This is a term that confuses people because it sounds like we simply do not know what happened. That is not entirely accurate. Cryptogenic stroke, which accounts for roughly 25 to 30% of all ischemic strokes, means that standard evaluation did not identify the cause. But research over the past decade has shown that many of these strokes are connected to paroxysmal atrial fibrillation, episodes of irregular heart rhythm that come and go and cannot be captured on a standard 12-lead ECG. They can only be detected with prolonged cardiac monitoring over days or weeks. The Crystal AF trial, published in the New England Journal of Medicine, found that extended cardiac monitoring identified atrial fibrillation in a significant percentage of patients initially classified as cryptogenic stroke.
Dr. Carter, you have mentioned atrial fibrillation several times now, and I can tell this is something you feel strongly about. You told me once that AFib is the sleeping giant of stroke risk in the 60-plus population. Why is this condition so dangerous, and what makes it so difficult to detect?
I use that phrase deliberately, Daniel, because that is exactly what atrial fibrillation is for millions of older Americans. A sleeping giant. Present, growing, doing damage, and completely invisible until the moment it is not. Let me explain what happens in the heart during atrial fibrillation. The upper chambers of the heart, the atria, normally contract in a coordinated, rhythmic way that efficiently pushes blood into the lower chambers, and from there, into circulation. In atrial fibrillation, the electrical signals that coordinate this contraction become chaotic. The atria quiver rather than pump, and when blood is not moving efficiently through the heart, it pools. Pooled blood forms clots. Those clots, sitting in the upper chambers of the heart, are one missed heartbeat away from traveling directly to the brain. The numbers are stark. A person with atrial fibrillation has 5 times the stroke risk of someone without it. Not 5% more, 5 times more. And according to the most recent data from the American Heart Association's 2024 statistical update, approximately 6 million Americans are currently living with atrial fibrillation. Experts estimate that number will double by 2050 as the population ages. Here is what makes AFib particularly dangerous for our audience today. Somewhere between 30 and 40% of people with atrial fibrillation experience no symptoms whatsoever. Their hearts are fibrillating in a way that produces no palpitations, no dizziness, no shortness of breath that they would connect to a heart problem. They feel completely normal, and then one morning they wake up unable to speak. There is also a subtype called paroxysmal atrial fibrillation. Episodes come and go, sometimes lasting minutes, sometimes hours. Between episodes, the heart rhythm looks completely normal on a standard ECG. This is why I tell patients that a normal ECG at their annual checkup is reassuring but not definitive. If you are over 60 and you have never had extended cardiac monitoring, that is a conversation worth having with your physician. There is one more connection I want to make here, and it is directly relevant to what we are going to discuss for the rest of today's conversation. Alcohol, even moderate amounts, can trigger acute episodes of atrial fibrillation in susceptible individuals. This phenomenon has its own name in cardiology. We call it holiday heart syndrome, first described in the 1978 by Dr. Philip Ettinger after observing clusters of AFib episodes in otherwise healthy people following weekend and holiday drinking. Certain foods, particularly those that dramatically spike blood sugar or create electrolyte imbalances, can also destabilize heart rhythm in people who already have underlying AFib risk. We will come back to this when we discuss specific fruits and evening habits.
Dr. Carter, I want to ask about something that most people never connect to stroke risk at all, and that is what happens to the body overnight in terms of hydration. You told me once that the most dangerous moment of the entire day for stroke may not be during physical exertion or emotional stress. It may be the moment a person wakes up in the morning. Why?
This is one of the most important and least discussed concepts in stroke prevention, Daniel. And I am glad you brought it up before we go any further, because it explains why so many of the habits and foods we discuss today become exponentially more dangerous when combined with the physiology of early morning. Let me describe what is happening inside the body between approximately 4 a.m. and 11 a.m. Doctors call this the morning surge, and it involves a cascade of simultaneous physiological changes that collectively create the highest stroke risk window of the entire 24-hour day. Beginning around 4 a.m., the adrenal glands begin releasing cortisol in increasing amounts. Cortisol is a stress hormone with many vital functions, including preparing the body for the demands of waking life. But cortisol also activates inflammatory pathways and increases the blood's tendency to clot. At the same time, the sympathetic nervous system begins to ramp up, releasing catecholamines, specifically epinephrine and norepinephrine. These hormones cause the heart rate to increase and the blood vessels to constrict, driving blood pressure upward. By the time most people are waking up, typically between 6 and 8 a.m., blood pressure has already climbed significantly from its overnight low. In healthy younger adults with flexible arterial walls, this morning surge is managed efficiently. In older adults with stiffer arteries, reduced vascular elasticity, and potentially compromised autoregulation, this surge lands on a cardiovascular system that is far less equipped to handle it smoothly. Now add dehydration. After 7 or 8 hours of sleep without fluid intake, the blood has become measurably more concentrated. The hematocrit, the proportion of red blood cells to plasma, is at its highest point of the day. Concentrated blood is stickier. It flows more slowly through already narrowed vessels. And a study published in the journal Neurology found that patients presenting with ischemic stroke had significantly elevated dehydration markers compared to matched controls, and that the degree of dehydration correlated directly with stroke severity. Platelet aggregation also reaches its daily peak in the early morning hours. The fibrinolytic system, the body's natural clot-dissolving mechanism, is at its weakest. So we have simultaneously elevated blood pressure, cortisol-driven inflammation, thickened blood, maximum platelet stickiness, and minimum clot-dissolving capacity, all happening at once, all converging in that window between 6 and 11 a. Now here is what I want every person watching to truly understand. Every poor decision made the night before, every fruit eaten at the wrong time, every medication skipped, every glass of alcohol, every hour spent sleeping in the wrong position, these all feed directly into how vulnerable the body is when that morning surge arrives. The night before is not separate from the morning. The night before is the setup.
That framework changes everything about how we think about our evening and nighttime habits. Dr. Carter, we have laid the foundation now, and I know our viewers are ready to get into the specifics. Before we do, I want to ask one more question here. Because there is a condition, you mentioned briefly, that affects blood flow in the neck, a condition that can be present for years without any symptoms, that affects a significant percentage of people over 65, and that dramatically increases stroke risk overnight. What is that condition, and how does it connect to everything we have discussed so far?
You are referring to carotid artery stenosis, and it is the perfect bridge into everything we are about to discuss. The carotid arteries are the two large vessels running up either side of the neck that supply the majority of blood to the brain. Like all arteries, they are susceptible to atherosclerosis, the gradual buildup of fatty plaques along the vessel walls. As those plaques grow, the channel through which blood flows narrows. When the narrowing exceeds about 70% of the vessel diameter, the risk of clot formation and stroke increases dramatically. Here is what makes carotid stenosis so dangerous. It is almost entirely silent. There are no symptoms until the vessel is severely narrowed or until a piece of plaque breaks loose and travels to the brain. I have had patients sit in my office with carotid stenosis greater than 70% who had no idea anything was wrong. They slept well. They exercised. They ate what they believed was a healthy diet. The only warning they ever received was a TIA, or a stroke. The American Heart Association recommends carotid ultrasound screening for adults over 65 who have multiple cardiovascular risk factors. Yet in my experience, the majority of patients at this age have never had one. If you are watching today and you are over 65 with high blood pressure, high cholesterol, diabetes, or a history of smoking, that screening conversation with your physician is worth having. It takes less than 30 minutes and requires no radiation, no needles, and no preparation. There is also an early warning sign that many people experience but rarely report to their doctor. A brief, sudden darkening or graying of vision in one eye, lasting seconds to minutes, sometimes described as a curtain dropping across the visual field. This is called amaurosis fugax, and it is caused by a small piece of plaque temporarily interrupting blood flow to the ophthalmic artery, a branch of the carotid. It is not a nuisance. It is a neurological emergency. If you or someone you know experiences this, call 911. Do not wait for it to resolve on its own, even though it almost always does. Now, with that foundation in place, I think we are ready to talk about what most people will find genuinely surprising. Because the first category of stroke risk factors we are going to examine is not smoking, not sedentary lifestyle, not family history. It is the fruit bowl sitting on your kitchen counter right now. And some of what I am about to share will likely change the way you approach your morning routine permanently. Carotid artery stenosis is actually the perfect bridge into everything we are about to discuss today, Daniel. And I want to make sure people understand why. Because it illustrates something fundamental about how stroke risk accumulates silently over decades. The carotid arteries are the two large vessels running up either side of the neck, supplying the majority of blood to the brain. Like every artery in the body, they are susceptible to atherosclerosis, the the gradual buildup of fatty plaque along the vessel walls. As that plaque grows, the channel narrows. When the narrowing exceeds approximately 70% of the vessel diameter, the risk of clot formation and stroke increases dramatically. Here is what makes this condition so dangerous. It produces no symptoms. None whatsoever. In most cases, I have had patients sitting across from me with carotid stenosis greater than 70% who felt completely healthy. They exercised. They ate what they believed was a nutritious diet. They slept well. The only warning their body ever gave them was a TIA, or a full stroke. The American Heart Association recommends carotid ultrasound screening for adults over 65 who carry multiple cardiovascular risk factors. Yet, in my experience, the majority of patients in that category have never had one. It takes 30 minutes, requires no radiation, no needles, no preparation of any kind. If you are watching today and you are over 65 with high blood pressure, high cholesterol, diabetes, or a history of smoking, that conversation with your physician is overdue. There is also one early warning sign that people experience but almost never report. A sudden, brief darkening of vision in one eye, sometimes described as a curtain dropping across the visual field, lasting anywhere from seconds to a few minutes. This is called amaurosis fugax. It is caused by a small fragment of plaque temporarily interrupting blood flow to the ophthalmic artery, a branch of the carotid. Most people assume it was eye strain or tiredness and never mention it to anyone. It is not eye strain. It is a neurological warning that a larger event may be imminent. If this happens to you or someone you love, call 911, even if the vision returns completely to normal in 2 minutes.
Dr. Carter, you have described TIA as a warning stroke that most people dangerously ignore because the symptoms resolve on their own. Can you tell us exactly what that 48-hour window looks like and why the fact that symptoms disappeared is actually the most misleading part of the entire experience?
This is one of the most important clinical realities I share with patients, and I repeat it in my practice constantly because the misunderstanding here costs lives. When someone experiences a TIA and the symptoms resolve, the natural human response is relief. The arm works again. The speech is clear again. Everything feels normal. And so the conclusion most people draw is that whatever happened has passed and they are fine. But here is what is actually happening inside the brain and the vasculature at that moment. The clot that caused the TIA dissolved or dislodged. But the underlying conditions that created that clot, the narrowed artery, the vulnerable plaque, the dysregulated blood chemistry, those conditions have not changed at all. In fact, the same artery that just produced one clot is now in an actively inflamed, unstable state. The risk of it producing another clot, a larger one that does not resolve, is at its absolute highest precisely in the hours and days immediately following a TIA. Research published in The Lancet and confirmed by multiple subsequent studies found that within 48 hours of a TIA, the risk of progressing to a full ischemic stroke reaches between 10 and 15%. Within 90 days, that cumulative risk climbs to between 10 and 20%. To put that in perspective, if 100 people experience a TIA today and do not seek immediate evaluation, somewhere between 10 and 20 of them will have a full stroke within 3 months. And the peak danger is not at the 3-month mark. It is in the first 2 days. The Express study, conducted at Oxford University and published in The Lancet, demonstrated that urgent same-day evaluation and treatment of TIA patients reduced the 90-day stroke risk by approximately 80%. 80%. The treatment itself is not complicated. It involves rapid imaging, antiplatelet medication, and identification of the underlying cause. But it requires the patient to seek care immediately rather than waiting to see if symptoms come back. I tell every patient the same thing. A TIA is not a near miss. It is a final warning. Treat it accordingly.
Dr. Carter, I want to ask about something that I know surprises a lot of people when they first hear it. You described atrial fibrillation earlier as a sleeping giant for stroke risk. But you also told me there is a specific subtype of AFib that is almost impossible to detect with standard testing, and that this subtype may be responsible for a significant percentage of strokes that doctors currently label as having no identifiable cause. What is that subtype, and how does someone know if they might have it?
You are asking about paroxysmal atrial fibrillation, And this is genuinely one of the most important concepts in modern stroke neurology. Let me explain why. Standard cardiac evaluation for most patients involves a 12-lead ECG, which records the heart's electrical activity for approximately 10 seconds. If the heart happens to be in normal sinus rhythm during those 10 seconds, the ECG looks completely normal. And many physicians, seeing a normal ECG, will reasonably reassure a patient that their heart rhythm appears fine. But paroxysmal atrial fibrillation is episodic. It comes and goes. A patient might experience hours or days of normal rhythm, punctuated by episodes of fibrillation lasting minutes to hours. Between those episodes, every ECG they have ever had looks perfectly normal. Yet during those episodes, the chaotic quivering of the atria allows blood to pool and clot in the left atrial appendage, a small pouch in the upper left chamber of the heart. Those clots can travel directly to the brain. The Crystal AF trial, published in the New England Journal of Medicine, implanted long-term cardiac monitors in patients who had experienced a cryptogenic stroke and found no obvious cause on standard evaluation. Over 36 months of monitoring, atrial fibrillation was detected in more than 30% of these patients. More than 30% of people who were told their stroke had no identifiable cause turned out to have AFib that standard testing simply never captured. Now, how does someone know if they might be at risk? The honest answer is that many people cannot know without extended monitoring, but there are patterns worth discussing with a physician. Unexplained fatigue. Episodes of feeling as though the heart is fluttering or beating irregularly, even briefly. Occasional shortness of breath that does not quite match the level of exertion. Waking up in the middle of the night with the heart beating in an unusual way. None of these are diagnostic, but in the context of stroke risk assessment in someone over 60, they are worth reporting and worth investigating. I also want to mention something that is directly relevant to our discussion today. Alcohol is one of the most well-established acute triggers for atrial fibrillation in susceptible individuals. This phenomenon, holiday heart syndrome, was first formally described in 1978. But the relationship goes beyond holiday celebrations. Even moderate amounts of alcohol on a regular basis can lower the threshold for AFib episodes in people who already have underlying risk. And as we will discuss later, certain foods that dramatically spike blood sugar or disrupt electrolyte balance can similarly destabilize cardiac rhythm in vulnerable individuals.
Dr. Carter, I want to stay on something you mentioned earlier about the morning hours being the most dangerous window of the day for stroke. You mentioned cortisol, blood pressure surges, and platelet activity all converging at once. But there is one additional factor in that morning window that most people have genuinely never connected to stroke risk. You told me once that what a person drinks, or more precisely does not drink, in the hours before sleep may be quietly thickening their blood throughout the night in ways that feed directly into that morning surge. Can you explain that connection?
This is one of those connections that seems almost too simple when you first hear it, and yet the physiology behind it is genuinely significant. Let me walk through what happens to the blood during a typical night of sleep. When you lie down to sleep, you stop taking in fluids. Over the next 7 to 8 hours, your body continues to lose water through breathing, through skin evaporation, and if you are sleeping in a warm environment, through mild perspiration. By the time you wake up in the morning, you have been in a state of progressively deepening relative dehydration for the entire night. What does dehydration do to blood? It reduces plasma volume, the liquid component of blood. As plasma volume decreases, the concentration of red blood cells and platelets per unit volume increases. The blood becomes measurably thicker and more viscous. Thicker blood flows more slowly, particularly through the small vessels that supply critical regions of the brain. And thicker blood, combined with elevated platelet aggregation in the early morning hours, creates significantly more favorable conditions for clot formation. A study published in the journal Neurology found that patients presenting with acute ischemic stroke had significantly elevated dehydration markers, specifically the ratio of blood urea nitrogen to creatinine compared to carefully matched control patients. And critically, the degree of dehydration correlated directly with stroke severity. The more dehydrated the patient was at presentation, the worse the neurological outcome. Now, layer this onto everything else happening in that morning window. Cortisol is surging. Blood pressure is climbing. Platelet aggregation is at its daily peak. The fibrinolytic system is at its daily nadir. and the blood is at its thickest and most viscous point of the entire day. All of this converges in those first hours after waking. Here is the practical implication, and it is genuinely actionable. Drinking 1 to 2 glasses of water immediately upon waking is not a minor wellness tip. For someone over 60 with cardiovascular risk factors, it is a meaningful stroke prevention strategy. It begins to rehydrate the blood before the morning surge hits its peak. It is free. It takes 30 seconds, and it is something that the vast majority of my patients were not doing before I explained why it mattered. I do want to add one thing here with a small smile, Daniel, because I say this to patients all the time. I tell them that the most powerful stroke prevention medication in their entire house costs nothing, requires no prescription, and is available from any tap in the kitchen. It is water. And yet somehow, it is the one thing most people consistently forget in the morning because they are rushing to make coffee. So drink the water first, then make the coffee.
Dr. Carter, before we move into the specific foods and habits, I want to ask about one more underlying risk factor that you mentioned connects directly to many of the things we will discuss: metabolic syndrome. You told me that a surprising percentage of Americans over 60 are walking around with metabolic syndrome without knowing it, and that this condition creates what you called a perfect biological environment for stroke. What exactly is metabolic syndrome, and how does it connect to the foods and sleep habits we are about to cover?
Metabolic syndrome is the term we use for a cluster of interconnected physiological abnormalities that, when present together, create a risk profile far greater than any single factor alone. The diagnostic criteria, established by the National Institutes of Health and the American Heart Association, require the presence of at least 3 of the following 5 conditions: abdominal obesity, specifically a waist circumference greater than 40 inches in men and 35 inches in women; elevated triglycerides above 150 milligrams per deciliter; low HDL cholesterol, below 40 in men and 50 in women; elevated fasting blood glucose above 100 milligrams per deciliter; and blood pressure at or above 130/85. According to data from the National Health and Nutrition Examination Survey, approximately 40% of Americans over 60 meet the criteria for metabolic syndrome, 40%. And a substantial portion of those individuals have never been explicitly told this by their physician, often because the individual components were addressed separately rather than recognized as an interconnected syndrome. Why does metabolic syndrome matter so profoundly for stroke risk? A meta-analysis published in the Journal of the American College of Cardiology found that the presence of metabolic syndrome is associated with a 2.27-fold increase in stroke risk. But more importantly for our conversation today, metabolic syndrome is not a static condition. It is dynamically responsive to daily habits. What you eat, when you eat it, and how well you sleep directly influence every component of metabolic syndrome, often within hours of a single meal or a single night of poor sleep. When someone with metabolic syndrome eats a high-sugar fruit in the evening, the blood glucose spike is larger and more prolonged than it would be in a metabolically healthy person. The triglyceride response is more dramatic. The inflammatory cascade is more pronounced. When that same person sleeps poorly, cortisol rises higher, insulin resistance worsens overnight, and the morning blood pressure surge is more extreme. This is why, as we go through the specific foods and habits in the next several parts of our conversation, I want viewers to understand that these are not isolated risks affecting only a small subset of the population. For the roughly 40% of adults over 60 with metabolic syndrome, and the additional percentage with pre-metabolic syndrome, these everyday habits are interacting with an already compromised physiological baseline. The margin for error is smaller. The consequences of routine poor choices are larger, and the opportunity for meaningful protection through simple, informed decisions is genuinely significant.
Dr. Carter, that context is invaluable. And now I think our viewers are genuinely ready for what comes next. Because we have spent this time building the foundation, understanding the mechanisms, the morning surge, the role of AFib, the silent dangers of TIA, and carotid stenosis, and now we understand why the physiological environment in so many people over 60 is primed for a stroke event. What I want to do now is start identifying the specific triggers. And the first category is going to surprise most people, because we are going to start in the kitchen with the fruit bowl. and specifically with a fruit that has been recommended as a heart-healthy breakfast staple for generations, one that millions of Americans over 60 eat every single morning, often alongside their blood pressure medication. Dr. Carter, what is the first fruit on our list? And what is it quietly doing to the aging cardiovascular system that almost nobody talks about?
The first fruit on our list is one that I genuinely hesitate to discuss in public settings, Daniel, because the backlash I receive from patients is immediate and passionate. I have had grown men look at me across my desk as if I just told them their golden retriever was dangerous. But the science is clear, and the stakes are too high for me to soften it. The first fruit is the banana. Now, before anyone turns this off in protest, let me be very precise about what I am saying. I am not saying bananas are universally dangerous. I am saying that for a specific and very common profile of adults over 60, eating bananas in certain quantities and at certain times creates a cardiovascular environment that can contribute directly to stroke risk. And that profile describes a significant percentage of the people watching today.
Dr. Carter, most people over 60 have been told their whole lives that bananas are heart healthy because of their potassium content. Can you explain exactly what changes after 60 that turns this long, trusted breakfast staple into something worth reconsidering?
The potassium story is the key, and it requires understanding something that most people are never taught about how the aging kidney functions. Potassium is an essential mineral. It supports healthy nerve function, muscle contraction, and yes, normal heart rhythm. In a younger, healthy body with fully functional kidneys, excess potassium is filtered out of the blood efficiently and excreted in urine. But kidney function declines with age. According to research published in the Clinical Journal of the American Society of Nephrology, glomerular filtration rate, the measure of how efficiently the kidneys filter blood, decreases by approximately 1% per year after the age of 40. By the time someone is in their late 60s or 70s, their kidney filtration capacity may be 30 to 40% lower than it was at its peak, even without any diagnosed kidney disease. Now, add medications. ACE inhibitors and ARBs, among the most commonly prescribed blood pressure medications in this country, reduce the kidney's ability to excrete potassium. Potassium-sparing diuretics do the same. Many people over 60 are taking one or more of these medications and have no idea that every banana they eat is adding potassium to a system that is already struggling to clear it. One large banana contains between 450 and 500 milligrams of potassium. When potassium accumulates in the bloodstream beyond the normal range, a condition called hyperkalemia develops. Mild hyperkalemia produces few obvious symptoms, but at the cardiovascular level, it disrupts the electrical conduction system of the heart. The resting membrane potential of cardiac cells shifts. The heart begins to conduct electrical signals abnormally. This creates arrhythmias. And arrhythmias in the context of stiffened arteries and age-related vascular changes create precisely the conditions for clot formation and embolic stroke.
Dr. Carter, you mentioned that the timing of when someone eats a banana matters just as much as how many they eat. You told me once that eating a banana at a specific time of day creates what you called a perfect storm inside aging blood vessels overnight. What is that perfect storm, and when exactly is the most dangerous time to eat one?
The most dangerous time is the evening, and here is exactly why. During the day, circulation is active. The kidneys are at peak function relative to their daily cycle, and any potassium load is processed more efficiently. But as evening approaches, several things change simultaneously. Circulation slows as the body begins preparing for sleep. Kidney filtration follows a circadian rhythm and is less efficient in the late evening hours. Many medications, including blood pressure medications taken in the morning, are reaching the tail end of their active period, meaning their effects on potassium excretion are still present, but their blood pressure control is waning. So eating a banana at 8 o'clock in the evening, alongside medications, when circulation is slowing and kidney filtration is at a daily low, means that potassium accumulates in the bloodstream during precisely the hours when the body is least equipped to handle it. Add the overnight dehydration we discussed in Part 2, which further concentrates everything in the blood, and by 4 or 5 in the morning, the blood chemistry profile in some of these individuals is genuinely alarming. I had a patient, a gentleman named Raymond, 67 years old, a retired carpenter from Columbus, Ohio, active man, sharp, took real pride in eating well. Every single morning, without fail, he sliced a banana over his oatmeal and took his blood pressure medication and his lisinopril with a large glass of orange juice. He had done this for over a year. His wife found him on the bathroom floor one morning. Left-sided weakness, slurred speech. At the hospital, his potassium level was critically elevated, his heart rhythm was abnormal, and scans confirmed a small but devastating ischemic stroke. He had no idea that what he believed was his healthiest morning habit had been creating a dangerous chemical environment in his blood every single night. The recommendation I give my patients is straightforward. If you are over 60 and taking any medication for blood pressure, heart rhythm, or fluid balance, limit yourself to half a banana per day, eaten in the morning, always alongside protein to slow absorption. Never before bed. And discuss your specific medication list with your physician or pharmacist, because the interaction profile varies considerably depending on the exact drugs involved.
Dr. Carter, the second fruit on your list is one that feels almost impossible to argue against, because it is small, it is sweet, and people eat it by the handful at every social gathering without a second thought. You told me that for someone with hidden vascular vulnerability after 60, grapes can trigger a specific inflammatory process inside the arterial walls that begins within hours of eating them. What is that process, and why are the seedless varieties sold in most American grocery stores actually the most dangerous version?
Grapes are deceptive precisely because they are small. When you eat a handful of grapes, your brain does not register it as eating a significant amount of sugar. But a single cup of seedless grapes contains approximately 23 grams of sugar, primarily glucose and fructose, in a form that enters the bloodstream with very little fiber to slow absorption. For comparison, that is roughly equivalent to eating 2.5 teaspoons of table sugar, delivered rapidly, in a package that feels like a light, healthy snack. In a metabolically healthy person, this sugar load is managed. Insulin responds. Glucose is cleared, and the system returns to baseline relatively quickly. But in the 40% of adults over 60 with metabolic syndrome, and the additional percentage with pre-diabetes or insulin resistance, the glucose spike is larger, the insulin response is slower, and the blood sugar remains elevated for longer. Here is where the vascular damage happens. When blood glucose spikes rapidly, it triggers a process called glycation, where sugar molecules attach to proteins in the arterial walls. This makes those walls stiffer and more prone to microscopic tearing. Simultaneously, elevated glucose activates inflammatory pathways that increase the production of reactive oxygen species, essentially damaging the delicate endothelial lining of the blood vessels from within. Over time, this repeated inflammatory insult creates exactly the arterial environment where plaques form, where clots develop, and where the small vessels feeding critical regions of the brain become progressively more fragile. You may not feel any of this happening. There is no pain, there is no obvious symptom, but the process is real, it is measurable, and it accumulates with every high-sugar meal or snack. As for the seedless varieties, you are correct to highlight them. Seedless grapes have been selectively bred over decades for sweetness. They contain significantly higher sugar concentrations than traditional seeded varieties. They are also almost universally larger. So a handful of seedless grapes from a modern American grocery store delivers a substantially larger sugar load than the same handful of traditional grapes would have 50 years ago.
Dr. Carter, the third fruit on our list is one that most people consider essentially water with flavor, and they eat it in large quantities during summer, believing it is one of the most hydrating and harmless foods possible. You mentioned that watermelon has a glycemic index that most people would find genuinely shocking, and that eating it in the evening creates a very specific problem for people with elevated cardiovascular risk after 60. What is that problem?
Watermelon is a wonderful example of a food where the perception and the physiological reality are quite far apart. Most people think of watermelon as basically flavored water. It is 92% water by weight. How could it possibly be a problem? The answer lies in glycemic index and glycemic load. The glycemic index of watermelon is approximately 72, which places it in the high glycemic category alongside white bread and instant oatmeal. Now, nutritionists often point out that the glycemic load of watermelon, which accounts for the actual amount of carbohydrate per serving, is lower because of its high water content. And that is true for a modest portion. But here is the reality I see in my practice. Nobody eats a modest portion of watermelon at a summer gathering or while watching television in the evening. They eat 3 or 4 slices, and at that volume, the glycemic load becomes clinically significant. For someone over 60 with any degree of insulin resistance, eating 3 or 4 slices of watermelon at 7 or 8 in the evening causes a meaningful blood glucose spike precisely during the hours when the body's insulin response is at its daily low point. That spike persists into the early sleep hours, creating the inflammatory vascular environment we discussed with grapes, but now occurring while circulation is slowing and the body is transitioning into its overnight state. The combination is far more damaging than either factor alone.
Dr. Carter, I want to ask about the fourth fruit on our list, because this one genuinely frightens me every time I think about how widespread it is as a morning habit in America. You have told me that grapefruit interacts with a specific enzyme in the liver and the intestine that is responsible for metabolizing more than half of all commonly prescribed medications, and that a single half of a grapefruit can amplify the blood levels of certain drugs to between 2 and 4 times their intended dose. Can you explain exactly what that enzyme is? Which medications are most dangerous in combination with grapefruit, and why this particular interaction has caused strokes in people who had no idea what was happening?
This is the interaction that I consider the most medically serious on our entire list today, and I say that with full awareness of everything else we are discussing. Because the grapefruit interaction does not operate through the gradual mechanisms of sugar spikes or potassium accumulation, it operates immediately, dramatically, and in ways that directly and acutely affect stroke risk. The enzyme in question is CYP3A4, which stands for cytochrome P453A4. This enzyme, located in the lining of the small intestine and in liver cells, is responsible for breaking down and metabolizing a remarkably broad range of pharmaceutical compounds as they pass through the digestive system. Think of it as the body's pharmaceutical processing system. Its job is to ensure that medications are absorbed at the correct rate and that blood levels remain within the therapeutic window, the range where the drug is effective without being toxic. Grapefruit contains compounds called furanocoumarins. When consumed, these compounds irreversibly inhibit the CYP3A4 enzyme. Irreversibly is the critical word here. The enzyme does not recover until the body produces new enzyme proteins, which can take 24 to 72 hours. This means that eating half a grapefruit on Monday morning can still be affecting your medication levels on Wednesday. You cannot simply separate the grapefruit from the medication by a few hours. The effect is not about timing. It is about enzyme destruction. When CYP3A4 is inhibited, medications that would normally be partially broken down during absorption enter the bloodstream at much higher concentrations than intended. The prescribing physician calculated the dose assuming normal enzyme function. Without that enzyme, the actual blood level of the drug can be 2, 3, or 4 times higher than the intended therapeutic dose. Now, let us talk about which medications matter most for stroke risk in our audience. Statins, specifically simvastatin and lovastatin, are among the most dramatically affected. These are among the most commonly prescribed medications in adults over 60. At 2 to 4 times normal blood levels, they can cause severe muscle breakdown, a condition called rhabdomyolysis, which releases myoglobin into the bloodstream that can damage the kidneys and dramatically alter blood chemistry in ways that increase stroke risk. Calcium channel blockers used for blood pressure and heart rhythm, including amlodipine and felidipine, can reach dangerously elevated blood levels after grapefruit consumption, causing excessive vasodilation, blood pressure instability, and in some individuals, cardiac rhythm disturbances that significantly increase stroke risk. Certain anticoagulants are also affected, and in some individuals, the blood-thinning effect at these elevated levels shifts from protective to dangerous, increasing hemorrhagic stroke risk. I had a patient, a woman named Margaret, 71 years old, a retired school teacher from Scottsdale, Arizona. She was meticulous about her health. Took her statin every morning, ate what she considered an extremely clean diet, every single morning for years. She had half a grapefruit with her breakfast, because she believed it was one of the healthiest things she could eat. She came to me after experiencing a TIA that her previous physician had classified as unexplained. When I reviewed her complete diet and medication history in detail, the pattern was immediately apparent. She had been unknowingly amplifying her statin and her calcium channel blocker to levels far above their intended doses every single day. The resulting blood pressure and vascular instability had almost certainly contributed to her event. Once she eliminated the grapefruit, her medication levels stabilized and her blood pressure became significantly more consistent. The FDA has issued formal drug safety communications about grapefruit interactions, most recently updated in 2021, and the list of affected medications now exceeds 85 individual drugs. If you are over 60 and taking any prescription medication, and you enjoy grapefruit or grapefruit juice, that conversation with your pharmacist is not optional. It is essential.
Dr. Carter, before we move to the remaining 5 fruits on our list, I want to ask something that I suspect many viewers are thinking right now. Because we have talked about bananas, grapes, watermelon, and grapefruit, and some people listening may be feeling a bit overwhelmed and wondering whether any fruit is actually safe for someone over 60 with cardiovascular risk factors. Are there fruits that are genuinely protective? And if so, what makes them different from the ones we have discussed?
Absolutely, and I am very glad you asked that, because I want to be clear that this conversation is not about eliminating fruit. It is about understanding which fruits work with the aging cardiovascular system and which ones work against it under certain conditions. The fruits with the strongest evidence for cardiovascular protection in older adults are the dark berries, blueberries, blackberries, strawberries, and raspberries. These fruits share several characteristics that make them genuinely beneficial. They have a low glycemic index, typically between 25 and 40, meaning they produce a modest and gradual rise in blood sugar rather than a spike. They are rich in anthocyanins, the compounds responsible for their deep color, which have been shown in multiple studies to reduce arterial stiffness, lower blood pressure, and decrease platelet aggregation. A study published in the American Journal of Clinical Nutrition found that regular blueberry consumption over 8 weeks produced measurable reductions in blood pressure and arterial stiffness in hypertensive adults. And unlike grapefruit, they have no significant interactions with common cardiovascular medications. The practical guidance I give patients is this: if you enjoy fruit, make berries your primary choice. Eat them in the morning, alongside protein, never alone on an empty stomach. Keep portions modest, around half a cup to 1 cup. And if you are taking any blood pressure, cholesterol, or blood-thinning medication, review your complete fruit intake with your pharmacist or physician once a year. Because the medication landscape for most people over 60 changes over time, and an interaction that did not exist 2 years ago may be relevant today. And now, Daniel, I think we should move to the remaining 5 fruits on our list. Because the next one involves something that millions of Americans drink every single morning, something that most people consider not just healthy but almost medicinal. And the combination of what it contains and the medications most people over 60 are taking creates a risk profile that I genuinely believe is one of the most under-recognized threats in senior nutrition today.
Dr. Carter, you mentioned that orange juice creates a specific problem when combined with blood-thinning medications that millions of seniors take daily, and that this combination has contributed to a type of stroke that is actually the opposite of a clot. Can you explain exactly what happens when high-dose vitamin C from orange juice meets anticoagulant therapy in an aging vascular system?
This is a nuanced but genuinely important interaction, and it is one that most people, including many physicians, do not think about in the context of stroke prevention. Let me walk through the mechanism carefully. Vitamin C, or ascorbic acid, at the doses delivered by a large glass of orange juice, which can contain between 60 and 90 milligrams in a standard 8-ounce glass, and significantly more in the fresh squeezed varieties, interacts with anticoagulant medications, including warfarin and some of the newer direct oral anticoagulants. In some individuals, high-dose vitamin C can potentiate the anticoagulant effect, meaning it pushes the blood-thinning effect beyond the therapeutic window. In others, paradoxically, it can interfere with vitamin K-dependent clotting factors and create unpredictable INR fluctuations. For someone on warfarin whose blood-thinning level is carefully calibrated, a sudden large dose of vitamin C on top of regular medication can shift the balance toward excessive anticoagulation. And excessive anticoagulation in the context of aging cerebral blood vessels, particularly vessels already weakened by years of hypertension or amyloid angiopathy, creates risk for hemorrhagic stroke rather than ischemic stroke. This is the stroke that goes in the opposite direction. Not a clot blocking blood flow, but a vessel rupturing and bleeding into brain tissue. And hemorrhagic stroke carries a 30-day mortality rate exceeding 40%. The citric acid in orange juice also deserves mention. Over years of regular consumption in quantities common in American households, citric acid contributes to a gradual erosion of the endothelial lining of small vessels, particularly in individuals whose blood pressure creates additional mechanical stress on those vessel walls. My recommendation is not to eliminate citrus fruits entirely. Half an orange eaten whole, with its fiber intact, is a very different physiological event than 8 ounces of juice. Whole fruit slows sugar absorption, moderates the vitamin C dose, and eliminates the concentrated acid load. If you enjoy orange juice and you take any blood-thinning medication, discuss your consumption specifically with your physician at your next visit. Do not assume it is safe simply because no one has ever told you otherwise.
Dr. Carter, the sixth fruit on our list is one that many seniors eat specifically for digestive health: figs. Most people consider figs a wholesome, natural food with a long history of medicinal use. You told me that figs contain a specific combination of compounds that creates 2 distinct problems for stroke risk in older adults taking common heart medications. What are those 2 problems?
Figs are a beautiful example of a food with genuine nutritional value that nonetheless carries specific risks for a particular population, and that population describes a significant percentage of our viewers today. The first problem is vitamin K content. Figs, both fresh and dried, contain meaningful amounts of vitamin K. For most people, dietary vitamin K is simply part of normal nutrition. But for the roughly 2 million Americans over 60 currently taking warfarin as anticoagulation therapy, vitamin K is the direct pharmacological antagonist of their medication. Warfarin works by blocking vitamin K-dependent clotting factors. When dietary vitamin K intake fluctuates, the medication's effect fluctuates with it. Eating figs inconsistently, sometimes 3 or 4 at a time, sometimes none for a week, creates the kind of INR instability that dramatically increases both clotting and bleeding risk. The second problem is oxalate content. Figs contain oxalic acid, which in the quantities consumed by regular fig eaters can contribute to microcrystalline deposits in the small vessels of the brain over time. This is not a dramatic acute event. It is the kind of slow, progressive vascular damage that compounds with other risk factors over years. In isolation, it would be unlikely to cause a stroke, but in an older adult whose cerebral small vessels are already managing the effects of hypertension, diabetes, or amyloid angiopathy, additional oxalate burden is not something the vascular system can easily absorb. For my patients who enjoy figs and are on anticoagulation, my recommendation is consistent daily portions rather than erratic large quantities, and a conversation with their anticoagulation clinic about timing relative to their warfarin dose.
Dr. Carter, the 7th fruit is one that is universally recommended for digestive regularity, and millions of seniors eat it every single day, specifically because their physician told them it was good for them. Dried prunes? You told me that the drying process does something to the sugar content of prunes that makes them dramatically more dangerous than the fresh version, and that their vitamin K content is among the highest of any commonly eaten fruit. What happens to prunes during the drying process that transforms them from a reasonable fresh fruit into something with a much more complicated risk profile?
This is one I genuinely enjoy explaining, because the chemistry here is quite elegant, even if the conclusion is inconvenient for anyone who relies on prunes as part of their daily routine. And I want to say, I understand why physicians recommend prunes for digestive health. The fiber content is real, the sorbitol helps with motility, and the recommendation is not wrong for a general adult population. But for older adults on anticoagulation or with significant metabolic syndrome, the picture is more complicated. When a plum is dried into a prune, the water content drops from approximately 87% to about 32%. All of the sugar that was distributed through that water volume becomes concentrated into a much smaller, denser package. A single fresh plum contains about 6.5 grams of sugar. A single dried prune contains about 10 to 11 grams of sugar, in a fraction of the weight and volume. People typically eat 3, 4, or 5 prunes at a time because they are small and because the recommended serving is often listed as 5 to 6 pieces. That serving delivers between 50 and 65 grams of sugar, with very rapid absorption because the fruit has essentially been pre-concentrated by the drying process. For someone with metabolic syndrome or insulin resistance, that sugar load in the morning, combined with blood pressure medication and perhaps other drugs whose absorption may be altered by the concentrated fruit acids, creates a significant metabolic spike at exactly the time the morning surge is already stressing the cardiovascular system. And on the vitamin K question, dried prunes have a vitamin K content that rivals leafy greens. A serving of 5 prunes can contain between 25 and 30 micrograms of vitamin K, a clinically significant amount for anyone on warfarin therapy. Combined with the sugar load, the concentrated organic acids, and the medication interaction potential, dried prunes occupy a genuinely complicated place in the nutrition profile of seniors on complex medication regimens. I always tell my patients on warfarin, think of your diet as part of your prescription. The consistency of what you eat matters as much as whether you take your pill. And prunes, eaten erratically in varying quantities, are one of the most common sources of the INR fluctuation I see in clinical practice.
Dr. Carter, the 8th fruit on our list surprised me considerably when you first mentioned it to me, because pineapple has a reputation as an anti-inflammatory, digestive health supporting food with compounds that many people believe are actively beneficial. You told me that there is a specific enzyme in pineapple that has a direct blood thinning effect, and that for the millions of seniors taking daily aspirin, this combination has caused serious bleeding events that most people would never have anticipated. What is that enzyme, and how does it interact with aspirin in the aging body?
The enzyme is bromelain, and this is a case where the very property that makes pineapple appealing from a health perspective, its natural anti-inflammatory and mildly anticoagulant effect, becomes a liability when layered on top of pharmaceutical anticoagulation. Bromelain is a proteolytic enzyme found primarily in the core and stem of the pineapple, though it is present throughout the fruit. It has genuine anti-inflammatory properties. It modestly inhibits platelet aggregation, and it has a mild anticoagulant effect through its action on fibrinogen, the protein that forms the structural scaffold of blood clots. In isolation, for a healthy adult with no cardiovascular medications, these properties are essentially neutral or mildly beneficial. The bromelain effect is too modest to create clinical problems in a pharmacologically uncomplicated system. But consider the medication profile of the average senior over 60 with cardiovascular risk. Low-dose aspirin, sometimes called baby aspirin, is taken by tens of millions of American adults over 60 for cardiovascular prevention. Aspirin irreversibly inhibits thromboxane, A2, reducing platelet aggregation for the entire lifespan of the affected platelets, which is approximately 7 to 10 days. When you add bromelain's independent antiplatelet effect to aspirin's effect, you are stacking 2 separate mechanisms of platelet inhibition simultaneously. In some individuals, this combination shifts the balance far enough toward anticoagulation to create meaningful bleeding risk. Not necessarily catastrophic bleeding, but the kind of slow, persistent microbleeding in fragile cerebral vessels that can contribute to hemorrhagic events over time. The FDA issued a warning about bromelain interactions with anticoagulant and antiplatelet medications in 2018, specifically noting the risk for patients on aspirin, warfarin, and related compounds. I want to be practical here rather than alarmist. A single slice of pineapple at a summer cookout is not a clinical emergency for someone on baby aspirin. But if you are someone who eats pineapple regularly, who drinks pineapple juice, or who takes bromelain supplements because you read online that they help with joint inflammation, and you are also taking aspirin or any other antiplatelet or anticoagulant medication, that is a specific conversation to have with your physician.
Dr. Carter, the 9th and final fruit on our list is one that I know will surprise a lot of viewers, because mango is widely promoted as a superfood, rich in vitamins and antioxidants, and beloved by many Americans, particularly during warmer months. You told me that for someone over 60 with any degree of insulin resistance, eating mango in the evening triggers a very specific overnight metabolic cascade that feeds directly into the morning surge we discussed in part 2. Can you walk us through exactly what happens inside the body during those nighttime hours after eating mango?
Mango is a fruit I have genuinely complicated feelings about, Daniel, because it is nutritionally generous in many ways. It is rich in vitamin C, folate, and several antioxidant compounds. The objection is not to mango as a food. The objection is to mango eaten at night by older adults with metabolic vulnerability, and that distinction matters enormously. A single medium mango contains approximately 45 to 50 grams of sugar, primarily fructose and sucrose, with a glycemic index ranging from 51 to 60 depending on the variety and ripeness. That sugar load is not dramatically different from what we discussed with watermelon or grapes, but mango has an additional characteristic that makes the nighttime timing particularly problematic for cardiovascular risk. Mango is very high in rapidly absorbable fructose, and fructose is processed differently in the liver compared to glucose. When large amounts of fructose arrive at the liver, it bypasses the normal regulatory steps that govern glucose metabolism and is converted directly to triglycerides. This is called fructose-induced lipogenesis. It is rapid, it is dose-dependent, and it happens regardless of whether the person considers themselves diabetic or not. Now, here is the overnight cascade. Someone eats a mango or a large serving of mango at 7 or 8 in the evening. The liver begins converting that fructose load into triglycerides. By 9 or 10 in the evening, circulating triglyceride levels are rising. As the person falls asleep and enters the period of overnight physiological vulnerability we described earlier, triglycerides continue to accumulate. Elevated triglycerides directly increase blood viscosity, the thickness of the blood. They also contribute to small, dense LDL particle formation, the most atherogenic form of cholesterol, which accelerates plaque buildup in cerebral arteries. By 4 or 5 in the morning, when the cortisol surge begins and platelet aggregation peaks, this person's blood is simultaneously thickened by overnight dehydration, laden with elevated triglycerides from the evening mango, and experiencing maximum morning cardiovascular stress. Each of these factors amplifies the others. None of them is visible. None of them produces a symptom that would lead someone to think something was wrong. But collectively, they represent a substantially elevated risk environment for a stroke event during those early morning hours. The simple recommendation is timing. If you enjoy mango, eat it in the morning, in modest portions, alongside protein. The body's metabolic machinery in the morning hours is much better equipped to handle that fructose load than it is at 9 in the evening. Evening is simply the wrong time for high fructose, high sugar fruit for older adults with any degree of metabolic vulnerability.
Dr. Carter, we have now covered all 9 fruits on our list. Before we move into the nighttime habits section, I want to make sure our viewers have a clear, practical framework for what to keep, what to limit, and what to reconsider entirely. Can you give us a simple decision framework that someone over 60 can actually use the next time they are standing in the produce section of their grocery store?
I love this question because it is exactly the right place to land after everything we have discussed. Knowledge without actionable guidance is just anxiety. And the last thing I want is for someone watching today to feel overwhelmed and conclude that eating any fruit at all is dangerous. That is not the message. Here is the framework I use with my own patients. Think about 3 categories. The first category is eat freely and often. This includes all dark berries, blueberries, blackberries, strawberries, and raspberries. These are your cardiovascular allies, low glycemic, anti-inflammatory, anthocyanin-rich, and with no significant medication interactions. Eat them in the morning with protein. Make them your primary fruit source. The second category is eat thoughtfully and in moderation. This includes apples with the skin on, which provide fiber that slows sugar absorption, pears, which have a relatively low glycemic index, and cherries, which contain compounds that support healthy blood pressure. For these fruits, portion size and timing matter. Eat them earlier in the day, not in the evening, and always alongside other food rather than alone. The third category is approach with specific awareness. This is where bananas, grapes, watermelon, oranges, figs, prunes, pineapple, and mango belong for people over 60 with cardiovascular risk factors and medication use. None of these are categorically forbidden, but all of them carry specific considerations related to sugar load, timing, medication interactions, or electrolyte effects that require personalized attention. Talk to your physician or pharmacist about your specific medication list. Pay attention to when you eat these fruits relative to your medications. And think about evening consumption differently than morning consumption. And one final piece of practical advice that applies universally. Never eat fruit alone on an empty stomach. The combination of fruit with protein, a small handful of nuts, a serving of Greek yogurt, some cottage cheese, substantially slows glucose absorption, reduces the glycemic impact, and gives the body's metabolic machinery time to manage the sugar load without producing the kind of spike that damages arterial walls over time. Now, what we have covered so far all happens while you are awake and have some degree of awareness and control. But Daniel, as I said earlier, the hours you spend asleep may actually be the most dangerous 8 hours of your day, because during sleep, you have no awareness, no ability to adjust, no ability to respond. And there are 9 specific things that millions of Americans over 60 do during those hours that are quietly and systematically building the conditions for a stroke. Let us talk about them now. Everything we have discussed so far happens while you are awake, Daniel. You have awareness. You have the ability to make a different choice. You can put down the banana, skip the evening mango, call your pharmacist about the grapefruit, but the moment you close your eyes, all of that conscious control disappears. For 7 or 8 hours, your body is entirely on its own. And what it does during those hours, and more importantly, what you have set it up to do through the positions and routines you have established over decades, determines in a very real way what kind of cardiovascular system wakes up the next morning. What I am about to describe are 9 specific nighttime habits that I have seen, repeatedly and predictably, in the histories of patients who experience strokes during or immediately after sleep. None of them are dramatic. None of them feel dangerous. Most of them feel like comfort. And that is precisely what makes them so insidious.
Dr. Carter, let us start with the first nighttime habit. Many people over 60 sleep completely flat without any pillow elevation because they read online that it is better for spinal alignment. You told me that for an aging brain, sleeping completely flat does something specific to the fluid surrounding the brain that creates pressure inside the skull throughout the night. What exactly is happening? And what is the symptom that most people experience but completely misinterpret every single morning?
Sleeping completely flat is one of those habits where the reasoning sounds perfectly sensible and the physiological reality is considerably more complicated. The concern here is not the spine. The concern is cerebrospinal fluid dynamics. The brain sits inside the skull, surrounded by cerebrospinal fluid, which serves as a hydraulic cushion, a chemical transport medium, and a waste clearance vehicle. This fluid is continuously produced and continuously reabsorbed. In a healthy, upright, or slightly elevated position, gravity assists the drainage of cerebrospinal fluid away from the brain and back into the venous circulation. When you lie completely flat, that gravitational assistance disappears. Cerebrospinal fluid production continues at its normal rate, but drainage becomes less efficient. Over the course of a full night of flat sleeping, intracranial pressure, the pressure inside the skull, rises measurably. In a younger adult with highly flexible cranial compliance, the brain and skull accommodate this pressure change without significant consequence. But in an older adult with reduced vascular elasticity, potentially with some degree of cerebral small vessel disease, or with arteries already narrowed by years of atherosclerosis, that elevated intracranial pressure imposes meaningful additional stress on blood vessel walls throughout the night. A study published in the Journal of Clinical Sleep Medicine demonstrated that even modest head elevation of 15 degrees produced measurable improvements in intracranial pressure and in cerebral venous drainage during sleep in older adults. Now here is the symptom that most people completely misinterpret. They wake up between 3 and 4 in the morning with a dull, throbbing headache, typically felt behind the eyes or at the base of the skull. They assume it is dehydration, or they slept on the wrong side, or it is just one of those things that happens as you get older. They drink some water, take an aspirin, and go back to sleep. But what that headache is actually communicating is that intracranial pressure has been elevated for several hours and the brain is registering that stress. It is not a nuisance symptom. It is physiological feedback that something about the overnight environment deserves attention. The practical solution is straightforward. Elevating the head of the bed by 4 to 6 inches, or using a wedge pillow that creates a 15 to 30 degree incline for the entire upper body, not just pushing the chin down toward the chest with a thick pillow, consistently reduces this overnight pressure buildup. It takes one night to implement and no prescription to obtain.
Dr. Carter, the second nighttime habit is stomach sleeping. And I know this is one that many loyal stomach sleepers in our audience will push back on immediately because they have slept this way for 40 or 50 years and feel perfectly fine. You told me there are two specific arteries in the neck that stomach sleeping compromises for the entire duration of sleep, and that the cumulative damage from this position over years is something most people would never connect to their morning dizziness or balance problems. Which arteries are involved, and what does 8 hours of compression actually do to them?
I have enormous sympathy for stomach sleepers. I really do. Because this position feels deeply comfortable for many people, often because it developed in childhood as a self-soothing behavior and has been reinforced over decades of association with restful sleep. Changing it feels genuinely disruptive. But I need people to understand what is happening anatomically, because the mechanism here is not subtle. When you sleep on your stomach, you cannot breathe face down into the mattress. So, you rotate your head to one side, almost always the same side, because we are extraordinarily consistent creatures of habit, even in our sleep. That rotation typically reaches between 60 and 90 degrees from the midline. Now hold that position for 7 hours and consider what it means for the structures inside your neck. Running alongside both sides of the cervical spine are the vertebral arteries. These are paired vessels that travel upward through small openings in the cervical vertebrae and supply blood directly to the brainstem, the cerebellum, and the posterior regions of the brain responsible for balance, coordination, visual processing, and the regulation of breathing and heart rate. When the neck is rotated significantly and held in that position, these arteries can become kinked or compressed, reducing blood flow through them. Research published in the Journal of Manipulative and Physiological Therapeutics used Doppler ultrasound to directly measure vertebral artery blood flow velocity during various degrees of cervical rotation and confirmed that extreme rotation, the kind that occurs during stomach sleeping, produces measurable reductions in vertebral artery flow velocity. Here is what makes this relevant for our audience specifically. The posterior circulation of the brain, the territory supplied by the vertebral arteries, is responsible for some of the most common and most frightening stroke symptoms that older adults experience. Sudden dizziness severe enough to prevent standing, loss of coordination, double vision, sudden difficulty swallowing, nausea without obvious cause. These symptoms, in the context of a TIA or a posterior circulation stroke, are often dismissed as inner ear problems or labyrinthitis or simply aging. But when I take a detailed history from a patient experiencing these symptoms and learn they have been a lifelong stomach sleeper, the connection becomes very difficult to ignore. I want to make something clear for anyone who has slept on their stomach for decades and is now quietly alarmed. I am not saying you have already caused irreversible damage. The body has remarkable compensatory capacity. But I am saying that continuing this habit after 60, when arterial elasticity has declined and the vertebral arteries themselves may have some degree of atherosclerotic narrowing, adds a cumulative and unnecessary risk that is entirely within your control to modify.
Dr. Carter, the third nighttime habit involves something that millions of Americans over 60 have adopted specifically for comfort and health reasons: sleeping in a recliner chair. Many people sleep in recliners because of back pain, acid reflux, or breathing difficulties. They have often been told by someone that it is better for them. You told me that recliners create a specific problem for the veins that drain blood away from the brain, and that this problem is actually worse in some ways than sleeping flat. What is happening in a recliner that makes it cardiovascularly problematic for older adults?
The recliner situation is one I encounter constantly in my practice, and I approach it with real care because the people sleeping in recliners are almost always doing so for legitimate reasons. Back pain is real. Acid reflux is real. Sleep apnea that feels better with elevation is real. I am not dismissing those reasons. But I do need to explain what the recliner position does to a specific vascular structure that most people have never thought about. When you sleep in a recliner, even a fully reclined one, the position tends to push the chin slightly toward the chest. This is not always dramatically obvious, but it is consistent. And in that chin forward position, the jugular veins, the large veins running down either side of the neck that are responsible for draining the majority of blood out of the brain and back toward the heart, become partially compressed. Think of the jugular veins as the brain's drainage highway. Blood that has delivered oxygen and nutrients to the brain needs an efficient exit route. When the jugular veins are compressed by cervical flexion, that drainage slows. Venous blood backs up slightly within the cranial vault. And venous congestion inside the skull raises intracranial pressure in a mechanism that compounds the cerebrospinal fluid problem we just discussed with flat sleeping, but through a completely different pathway. In individuals with already elevated baseline intracranial pressure, perhaps from underlying venous insufficiency or from medications that affect fluid balance, recliner sleeping can create a sustained overnight elevation of pressure inside the skull that is clinically meaningful. There is a solution that preserves the benefits of elevation while avoiding the chin compression problem. A properly sized wedge pillow or an adjustable bed frame that elevates the entire torso on a gradual incline rather than bending at the waist achieves the elevation people are seeking without the jugular compression. If you are sleeping in a recliner for acid reflux or back pain, I strongly recommend discussing adjustable bed options with your physician because the right setup can address all of those issues without the vascular downside.
Dr. Carter, the fourth nighttime habit is one I genuinely did not anticipate being on this list, and I suspect most of our viewers feel the same way: sleeping under a heavy blanket. This sounds almost impossibly harmless. You told me that heavy blankets create a specific cardiovascular burden for older adults during sleep that is directly related to how the aging heart responds to temperature regulation overnight. What is actually happening under that comforter?
I want to be honest with you, Daniel. When I first explain this one to patients, I get the look. You know the look. The one that says, "Seriously? Now you are coming after my blanket?" I understand completely. But the physiology here is genuine, and it is particularly relevant for older adults with any degree of heart disease or hypertension. Here is the mechanism. When the body becomes too warm during sleep, the thermoregulatory system responds by increasing peripheral blood flow to the skin surface, a process called cutaneous vasodilation. This is the body's attempt to radiate excess heat. But cutaneous vasodilation requires increased cardiac output. The heart has to pump more blood to the skin surface. In a healthy, younger heart with ample reserve capacity, this increase is managed effortlessly. In an older heart, particularly one managing hypertension, any degree of coronary artery disease or diastolic dysfunction, that increased overnight demand can push the heart toward its functional limits. Cardiac output increases. Blood pressure fluctuates. In some individuals, this overnight thermal stress contributes to the kind of nocturnal blood pressure elevation that directly feeds into the dangerous morning surge we described in Part 1. Add to this the dehydration component. A heavy blanket in a warm bedroom causes mild but continuous perspiration throughout the night, accelerating the overnight blood concentration process we discussed earlier. By morning, the blood is thicker. The heart has been working harder than it should have been, and the cortisol surge arrives on a cardiovascular system that has already been under thermal stress for 7 hours. The research-supported optimal sleeping temperature is between 65 and 68 degrees Fahrenheit. At this temperature, the body naturally enters deeper, more restorative sleep stages. Thermoregulation requires minimal cardiac effort, and overnight blood pressure follows its healthy dipping pattern more reliably. If your bedroom is warmer than this, and you are using a heavy blanket, you are inadvertently creating a cardiovascular environment that works against you every night.
Dr. Carter, the fifth nighttime habit is one that a surprisingly large number of people over 60 engage in without realizing it: sleeping with one arm extended overhead, tucked under the pillow, or draped over the side of the bed. You told me this creates a compression problem in a specific blood vessel that most people have never heard of, and that the symptom it produces in the morning is one of the most commonly dismissed warning signs in senior health. What vessel is involved, and why is the morning numbness or tingling that results actually worth taking seriously? Dr. Carter, you mentioned at the end of part 5 a cleaning system inside the brain that most people have never heard of, a system that, when disrupted night after night, may be accelerating cognitive decline. The sixth nighttime habit on our list involves disrupting this system through fragmented, restless sleep. Can you explain what this system is, why it only activates during specific sleep stages, and what the connection between disrupted sleep and Alzheimer's risk actually looks like in the research?
This is the discovery that I believe every single person over 60 in America deserves to understand, because it reframes sleep from a passive rest period into an active, irreplaceable biological maintenance process. And it changes everything about how seriously we should take the quality, not just the quantity, of our nightly sleep. The system is called the glymphatic system. It was formally identified and described by Dr. Maiken Nedergaard and her team at the University of Rochester Medical Center and published in the journal Science in 2013. The glymphatic system is essentially the brain's waste clearance network. During deep, uninterrupted sleep, the cells that surround the brain's blood vessels, called glial cells, shrink in size by approximately 60%. This shrinkage dramatically increases the space between brain cells. Cerebrospinal fluid then pulses rhythmically through these enlarged channels, flushing out metabolic waste products that have accumulated during the day's neural activity. The waste products being cleared include amyloid beta and tau proteins. These are the exact proteins found in pathological concentrations in the brains of Alzheimer's patients. Amyloid beta forms the plaques. Tau forms the tangles. And the glymphatic system's primary job, executed every single night during deep sleep, is to prevent those proteins from accumulating to dangerous levels. A landmark study published in the Journal of Neuroscience demonstrated that glymphatic clearance is significantly more efficient during side sleeping than in any other position, and that sleep fragmentation, repeated interruptions of deep sleep regardless of total sleep duration, dramatically reduces the effectiveness of this overnight clearance process. Now, here is what this means practically. The sixth nighttime habit that raises stroke and cognitive decline risk is not a dramatic behavioral failure. It is simply sleeping in a way that chronically disrupts the deep sleep stages where glymphatic activity occurs. This includes sleeping in a position that causes frequent microarousals, sleeping with untreated pain that causes repeated awakening, sleeping in an environment with noise or light that fragments sleep architecture, and sleeping with untreated sleep apnea, which we will discuss in a moment. Every night of fragmented sleep is a night when the brain's cleaning crew could not finish the job. Over months and years, the proteins that were not cleared begin to accumulate. And accumulation of amyloid beta and tau is not just a marker of Alzheimer's risk. It is also a marker of cerebrovascular disease risk, because amyloid deposition in the walls of cerebral blood vessels, a condition called cerebral amyloid angiopathy, directly weakens those vessels and increases hemorrhagic stroke risk. The connection between sleep quality and stroke risk is therefore not just about blood pressure and cardiac rhythm. It runs directly through the brain's own maintenance biology.
Dr. Carter, you mentioned sleep apnea as a major disruptor of glymphatic function, and I know this condition affects a significant percentage of our audience without them knowing it. You told me that the connection between untreated sleep apnea and stroke risk is one of the most dramatic and most underappreciated relationships in all of cardiovascular medicine. What is the actual magnitude of that risk, and what are the signs that someone might have sleep apnea without realizing it?
The numbers on sleep apnea and stroke are genuinely striking, and I want to share them clearly because they matter for a large proportion of the people watching today. Research published in the New England Journal of Medicine by Dr. H. Clar Yagi and colleagues found that patients with obstructive sleep apnea had a significantly elevated risk of stroke or death compared to those without it, even after controlling for other cardiovascular risk factors. Subsequent research has found that between 50 and 70% of all stroke patients, when evaluated after their event, are found to have obstructive sleep apnea that was present but undiagnosed before the stroke occurred. Let me explain the mechanism, because it is multifactorial and interconnected in ways that make sleep apnea uniquely dangerous for stroke risk. During an apnea episode, breathing stops. Oxygen levels in the blood drop. The brain, detecting hypoxia, sends an emergency signal that wakes the person partially, often without full conscious awareness, just enough to restore muscle tone and resume breathing. This cycle can repeat dozens or even hundreds of times per night. Each episode triggers a surge in sympathetic nervous system activity. Blood pressure spikes. Heart rate accelerates. Cortisol and catecholamines flood the system. Platelet aggregation increases. Over a full night of repeated episodes, this produces cumulative cardiovascular stress that is roughly analogous to spending the night under repeated acute stress events. The heart and vascular system never truly rest. Morning blood pressure in untreated sleep apnea patients is often dramatically elevated, precisely because of this overnight cycle of repeated autonomic activation. Untreated sleep apnea is also one of the most potent triggers for atrial fibrillation. The intermittent hypoxia, the mechanical stress on the heart from repeated breathing efforts against a closed airway, and the autonomic dysregulation all contribute to the electrical instability that produces AFib. And we have already discussed at length what AFib does to stroke risk. The signs that suggest possible sleep apnea are worth knowing. Loud, irregular snoring, particularly snoring interrupted by pauses and then resumed with a gasping or choking sound. Waking up feeling unrefreshed despite apparently adequate sleep duration. Daytime drowsiness that seems disproportionate to how much sleep was obtained. Morning headaches, which reflect the overnight hypoxia and elevated intracranial pressure from impaired breathing. And in men particularly, frequent nighttime urination, which is driven by the atrial natriuretic peptide released in response to the negative intrathoracic pressure created during apnea events. If you or your bed partner recognize these patterns, a sleep study is warranted. And the evidence supporting CPAP therapy is compelling. Studies have shown that consistent CPAP use reduces stroke recurrence risk by more than 50% in patients who have already had a stroke. For primary prevention, the benefit is similarly meaningful.
Dr. Carter, the seventh nighttime habit is one that many people engage in, not out of carelessness, but out of genuine practical difficulty. Skipping evening medications because of side effects, drowsiness, or simply forgetting. You told me that for a specific category of blood pressure medication, missing the evening dose creates a window of cardiovascular vulnerability that opens precisely during the most dangerous hours of the morning surge. Which medications are most critical to take consistently? And why does the timing matter as much as whether you take them at all?
This is a conversation I have had more times than I can count, and it always begins the same way. A patient tells me they take their blood pressure medication most mornings, but sometimes skip it if they are in a hurry. Or they move their dose around depending on what time they wake up, or they stopped their evening medication because it was making them feel drowsy at 9 o'clock. And I always say the same thing. I understand completely. And I need you to understand what is happening inside your vascular system on the nights and mornings when that medication is absent. Antihypertensive medications, particularly ACE inhibitors, ARBs, and calcium channel blockers, work by maintaining a baseline of vascular tone and blood pressure control that the body cannot reliably maintain on its own after 60. When these medications are taken consistently, they help ensure that the morning cortisol surge does not push blood pressure to the dangerous peaks that create stroke risk. When they are skipped, particularly for an evening dose, blood pressure often climbs through the overnight hours and is at its highest precisely when it should be protected by medication. There is also a concept in cardiovascular medicine called chronotherapy that I want to mention here because it is clinically relevant and not widely known outside of specialist practice. Research published in the European Heart Journal, the HYGIA chronotherapy trial involving nearly 20,000 patients, found that patients who took their antihypertensive medication at bedtime rather than in the morning had significantly lower rates of major cardiovascular events, including stroke, compared to those who took the same medication in the morning. The reason is that bedtime dosing provides maximum medication effect during the overnight hours and the early morning period when cardiovascular risk is highest. I had a patient, a woman named Dorothy, 73 years old, a retired librarian from Portland, Oregon. She had been on 2 blood pressure medications for years and was extremely consistent about her morning dose. But her physician had recently added a 3rd medication to be taken at bedtime. Dorothy found it made her slightly groggy at her usual bedtime reading time, so she quietly stopped taking it after 2 weeks without telling anyone. 4 months later, she experienced a hemorrhagic stroke at 5:30 in the morning. Her overnight blood pressure monitoring, reviewed retrospectively, showed dramatic, uncontrolled surges in the early morning hours that the missing medication would have substantially blunted. Dorothy recovered, but incompletely. She told me from her rehabilitation bed, if I had known that drowsiness at 9 p.m. was going to cost me this, I would have just gone to bed earlier. If a medication is causing side effects that make you want to stop taking it, that conversation belongs with your physician, not in a private decision to simply discontinue. There are almost always alternatives.
Dr. Carter, the eighth nighttime habit is one that surprises people because it involves the bedroom environment rather than anything they actively do. Sleeping in a cold room without adequate neck protection. You told me that cold air exposure to the neck during sleep triggers a specific vascular reflex that can be particularly dangerous for older adults waking up in the morning. What is that reflex, and why does the morning transition from a cold bedroom into an upright position create a window of heightened stroke risk?
Cold and the cervical vasculature have a relationship that most people never think about, and it is worth understanding clearly for anyone whose bedroom drops below 60 degrees Fahrenheit during winter months, which describes a very large percentage of American homes. The neck is anatomically unusual in that it is one of the few regions of the body where major blood vessels, the carotid arteries, and the vertebral arteries run very close to the skin surface with relatively little insulating tissue between them and the external environment. When cold air contacts the neck during sleep, it triggers a reflex vasoconstriction of these cervical vessels, a narrowing of their diameter in response to thermal input. This is the same reflex that causes your face to flush in the cold. The vessels constrict to preserve core body temperature. In a younger person with elastic, fully patent arteries, this constriction is modest and entirely reversible. But in an older adult whose carotid or vertebral arteries already carry some degree of atherosclerotic plaque, sudden vasoconstriction narrows an already compromised lumen further. Blood flow through these vessels to the brain decreases, and if a piece of unstable plaque is present, the mechanical stress of vasoconstriction, followed by the rapid vasodilation that occurs when the person warms up, can contribute to plaque rupture, which is the event that triggers thrombotic stroke. The morning transition makes this worse. When a person waking in a cold bedroom moves from horizontal to upright, blood pressure must rapidly adjust to maintain cerebral perfusion against gravity. In a cold, constricted vascular system, this orthostatic adjustment is less efficient. Blood pressure transiently drops, then surges as the body overcompensates. For someone with compromised cerebrovascular reserves, that transient pressure swing in the context of an already stressed morning vascular environment is genuinely meaningful. The practical recommendations are straightforward. Keep the bedroom at 65 to 68 degrees Fahrenheit, which is optimal for both sleep quality and vascular safety. If you live in a climate where overnight temperatures drop significantly, wear a light scarf or turtleneck to bed, which sounds eccentric until you understand the physiology. And move slowly when rising in the morning. Sit at the edge of the bed for 30 to 60 seconds before standing. That simple pause gives your vascular system time to adjust before you demand it perform against gravity.
Dr. Carter, the ninth and final nighttime habit is one we touched on in our food discussion, but that deserves its own full examination in the context of sleep. Eating a heavy meal and drinking alcohol close to bedtime. You told me about a patient whose story illustrates this perfectly. A man whose evening routine was something millions of Americans would recognize as completely ordinary, and whose outcome was devastating. Can you share that story, and then explain exactly what the combination of a full stomach and alcohol does to the cardiovascular system during the critical hours between midnight and 6 in the morning?
I want to tell you about Gerald, a man who deserved better than what happened to him. Gerald was 75 years old, a retired farmer from Lincoln, Nebraska, a man of remarkable discipline and genuine physical strength, even at his age. His one consistent joy in life was his evening routine. Dinner at 7, a glass of bourbon at 8, bed by 8:30. He had done this for 30 years. It was comfort. It was ritual. It was earned, in his mind, after a lifetime of hard work. One winter evening, his family had gathered for a holiday celebration. The dinner was generous: turkey, mashed potatoes, gravy, pie, followed by Gerald's customary bourbon. He felt satisfied and content. He went to bed at his usual time. Around 4:15 in the morning, his wife reached across the bed and found him unresponsive. He was rushed to the hospital where imaging revealed a massive ischemic stroke in the frontal lobe. Laboratory analysis showed elevated post-meal triglycerides, measurably dehydrated blood, and evidence of overnight cortisol rebound from alcohol metabolism. There was no atrial fibrillation, no skipped medication, no obvious precipitating event. Just the cumulative effect of one ordinary evening translated into a catastrophic morning. Gerald survived, but he never spoke clearly again. His wife, who became his full-time caregiver, said something to me that I have never forgotten. She said, "We thought we were doing everything right. We just did not know that dinner and a drink could take him from me like that." Let me explain the physiology of what happened to Gerald, because it applies to millions of people watching today who have a similar evening routine. When you eat a large meal, particularly one high in fat, sodium, and refined carbohydrates, the digestive system demands a significant portion of the body's total blood volume. Blood is redirected from the brain and the peripheral circulation toward the mesenteric arteries that supply the gut. In a younger, healthy person, this redistribution is managed seamlessly, with no meaningful effect on cerebral perfusion. In an older adult whose cerebral autoregulation is already less efficient, this blood redistribution can create brief transient drops in brain blood flow during the digestive hours that follow the meal. Alcohol then enters the equation. Alcohol is initially a vasodilator. It relaxes the smooth muscle in vessel walls, widening the lumen and dropping blood pressure. This is why people feel warm and relaxed after a drink. But as alcohol is metabolized over the following 3 to 4 hours, its vasodilatory effect reverses. The vessels constrict. Blood pressure rebounds, sometimes climbing above pre-drinking levels. The heart, which was working harder to compensate for vasodilation, now must adjust rapidly to vasoconstriction. In an older cardiovascular system with reduced regulatory flexibility, this pressure oscillation is not trivial. The American Journal of Hypertension published research specifically examining this pattern and found that alcohol consumption within 3 hours of sleep disrupted the natural overnight blood pressure dipping that protects cardiovascular health during sleep. In individuals who already had hypertension, this disruption was more pronounced and more prolonged. Add overnight dehydration, which alcohol accelerates through its diuretic effect on the kidneys, and by 4 or 5 in the morning, Gerald's blood was thick, his blood pressure was oscillating in an uncontrolled pattern, his cortisol surge was beginning, and the protective dip that should have lowered his cardiovascular risk overnight had never occurred. Every single risk factor we have discussed today converged on one ordinary evening. The guidance is concrete and actionable. Finish eating at least 3 hours before bed. If you drink alcohol, stop at least 4 hours before you intend to sleep. Drink a full glass of water with dinner and another before sleeping. Take a 15-minute walk after the evening meal, not strenuous exercise, simply movement that supports digestion, stabilizes blood sugar, and gives the cardiovascular system a chance to settle before you ask it to manage 8 hours of sleep. And now, Daniel, we have covered all 18 risk factors, 9 foods, and 9 nighttime habits. What I want to do in our final section is bring everything together into something actionable, practical, and empowering. Because knowledge without a clear path forward is simply anxiety. And our viewers deserve better than anxiety. They deserve a plan.
Dr. Carter, we have now covered 18 specific risk factors across 9 foods and 9 nighttime habits. Before we close, I want to make sure every single person watching today knows the one set of letters that could save their life or the life of someone they love. You told me that the single most important factor in stroke survival is not the hospital, not the medication, and not the surgeon. It is the 5 letters most people know only partially, and the 2 additional letters that were added to the original acronym because they capture warning signs that far too many people were missing. What are those letters, and why does every second of delay after stroke symptoms carry a cost that most people would find genuinely shocking?
The letters are be fast. And I want every person watching to commit this to memory before this video ends, because the window between recognizing a stroke and receiving treatment is the single most consequential factor in determining whether someone walks out of the hospital or requires lifelong care. The original acronym was FAST: face drooping, arm weakness, speech difficulty, time to call 911. The American Stroke Association updated this to BE FAST in 2020 to capture 2 additional warning signs that account for a significant percentage of missed strokes. particularly posterior circulation strokes affecting the brainstem and cerebellum. B stands for balance. Sudden loss of balance or coordination, feeling as though the floor is tilting, or being unable to walk a straight line without apparent cause. E stands for eyes. Sudden vision changes in one or both eyes. Double vision, or that curtain-dropping sensation I described earlier. Amaurosis fugax. F stands for face. Ask the person to smile. If one side droops or does not move symmetrically, that is a warning sign. A stands for arms. Ask the person to raise both arms to shoulder height. If one drifts downward or cannot be raised, that is a warning sign. S stands for speech. Ask the person to repeat a simple sentence. Slurred words, strange substitutions, or inability to speak or understand speech are all warning signs. T stands for time. Call 911 immediately. Do not drive yourself. Do not wait to see if it improves. Do not take aspirin and lie down. Call 911 and tell them you suspect a stroke. Note the exact time symptoms began, because that time determines which treatments are available. Here is the number that puts the urgency in perspective. Every minute a stroke goes untreated, approximately 1.9 million brain cells die. The treatment window for clot-dissolving medication is 3 to 4.5 hours from symptom onset. For mechanical thrombectomy, where a catheter removes the clot directly, the window extends to 6 to 24 hours in eligible patients. But the outcomes are dramatically better the earlier treatment begins. I tell patients, if you are uncertain whether you are having a stroke, call 911 anyway. There is no penalty for a false alarm. There is a catastrophic penalty for a missed one.
Dr. Carter, we have covered an enormous amount of ground today. Before our final thoughts, I want to ask for something our viewers can genuinely act on starting tonight. Not a list of 20 things, but the single most impactful change someone over 60 can make immediately that addresses multiple risk factors at once. If you could give every person watching one thing to do differently starting this evening, what would it be?
I have thought about this question more times than I can count, Daniel, because the most common failure in preventive medicine is not lack of knowledge. It is the gap between knowing and doing. People hear 18 risk factors and feel overwhelmed and change nothing. So let me make this as simple as possible. The single most impactful change is this. Tonight, do 3 things before you go to bed. First, drink 1 full glass of water. Second, if you take any evening medication, take it without skipping. And third, lie on your left side when you get into bed, with your head elevated between 15 and 30 degrees using a wedge pillow or by slightly elevating the head of your bed. Those 3 actions simultaneously address blood viscosity, overnight blood pressure control, glymphatic clearance, and intracranial pressure. They cost nothing. They require no prescription. They take less than 5 minutes. And done consistently, they represent a genuinely meaningful reduction in the overnight stroke risk environment that we have spent this entire conversation describing. Start with those 3. Build from there. Your brain and your heart will work with you if you give them the conditions to do so.
Dr. Carter, those 3 steps are as clear and actionable as anything I have heard in 30 years of medicine. Thank you for everything you have shared today. And to everyone watching, if this conversation gave you something your last doctor's appointment never did, I want to ask you to do 3 things right now. Hit the like button because it helps this information reach the people who need it most. Share this video with someone you love over 60, a spouse, a sibling, a close friend, because you may be giving them something their physician has never once mentioned. And subscribe to the Stronger Seniors podcast with the notification bell on, so you never miss the conversations that protect your health and the health of the people you care about most. We are genuinely honored to be part of your health journey. This channel is for educational purposes only and is not a substitute for professional medical advice. Always consult your healthcare provider before making health-related decisions. We will see you in the next episode. Now, before we say goodbye, here is something I love ending every episode with. A quick health knowledge challenge to keep your mind sharp, active, and engaged every single day. Because staying mentally active is one of the most powerful things you can do for your brain after 60. Here is today's challenge. We talked about the glymphatic system, the brain's overnight cleaning crew that removes amyloid beta and tau proteins linked to Alzheimer's disease. Based on everything Dr. Carter shared today, here is the question. The glymphatic system works most efficiently during one specific sleep position. What is that position? And as a bonus, name one of the two proteins it clears from the brain that are directly associated with Alzheimer's disease. Drop your answer in the comments below. There are no wrong answers here, only a community of curious, engaged people learning and protecting their health together. I read every single comment, and I look forward to seeing your responses.